I'm Dr Gemma Sharp. I'm a population health researcher with a background in reproductive biology. And the title of my talk includes the classic line, are you on your period or something, which some of you might have heard, and some of you might have also asked people. It's not a particularly helpful question, and I think if I was going to rephrase it, it would be something more along the lines of, in what ways are menstrual and mental health linked, and how can we maximise mental well-being in relation to menstruation? Which I understand that's not really going to catch on, but that's the more helpful version. And I think my answer to that question would be, we don't really know, but we need more research on menstrual and mental health. So that's the very short version of my talk. But I've got like at least 30 more slides. So I'm going to start with a little bit of history to set the scene. So some of you might have heard of hysteria before. So hysteria was the first mental disorder that was ever attributed to women, and it's not recognised as a mental disorder anymore. It's always kind of been a bit of an umbrella term for anything troublesome or problematic that happens to women, or that's sort of pertaining to women but actually troublesome or problematic for any other people that know them. So the symptoms can include things like anxiety, shortness of breath, insomnia, fluid retention, loss of appetite, loss of sexual desire, and then paradoxically sexually forward behaviour, and generally a tendency to cause trouble for others, which I quite like.
Basically describing me.
Hysteria was first described in ancient Egypt, but we've got the ancient Greeks to thank for the suggestion that it was caused by the uterus moving around the body. So this guy, Aristeas of Cappadocia, he described the uterus as an animal within an animal, and he said it wanders around the female body, putting pressure on other organs and just generally sending them into disarray. Bear with me. The uterus is actually there we go. Yeah. So and there are also Hippocratic texts in the 5th and 4th century BC that said that childless women were the most likely to get hysteria, and the key problem causing hysteria was the retention of menstrual blood within the uterus. And that was then kind of getting stagnant and poisonous. And the reason that it was getting stuck there was because the vagina wasn't sort of wide enough because of an unsatisfactory sexual life. So basically the vagina hadn't been made wide enough by penises, so the blood couldn't get out, and then that meant that women developed hysteria. So you can kind of guess where this is going. So the suggested treatment was just basically to must get married, and have loads of sex within the bounds of marriage. And so these beliefs and variations on them persisted well into the 17th century AD. The kind of wandering womb and stagnant menstrual blood theory kind of lost popularity, I think probably rightly so, but hysteria was still diagnosed as a mental disorder right up until the 1980s, when it was finally taken out of the Diagnostic and Statistical Manual of Mental Disorders. So that was a bit of history. I'm not a historian, so I'm going to move on to some science. That's where I feel a little bit more comfortable. So hopefully the science will help you understand how some of the problems with those kind of early theories about the uterus and mental health. So this is the organ that the ancient Greeks thought was responsible for all of women's mental health problems. The uterus is also sometimes called the womb. The uterus and the womb are the same thing. just in case that was not clear. Actually, so like this bit here is the uterus, and then you've got your ovaries, fallopian tubes, cervix and vagina making up the rest of the female reproductive system. The kind of darker bit in the middle is the endometrium, and that is a layer that fills with blood and then breaks down, releasing the blood through the vagina, which is totally wide enough without the need of that helpful, well-meaning penis. This bit on the outside is the kind of like bigger bit on the outside is the myometrium. That's the muscle layer of the uterus, and that contracts a little bit during menstruation to help move the blood out, and then also famously during labour to move the baby out. And it's those kind of little contractions that can cause period pain. So on this diagram, we can see the blood kind of filling up inside the endometrium and then coming out. So this bottom panel here. So the blood being released during period or menses or menstruation, all the same thing. And then the endometrium fills with blood again, and then this is all controlled by hormones, which you can see in this next panel up. So chiefly follicle-stimulating hormone and luteinizing hormone, which are both released from the brain, and estrogen and progesterone, which are released from the ovaries. And you can see that these show pretty sizable fluctuations throughout the menstrual cycle. So in the first part of the cycle, estrogen, which is the kind of grey one, if you can see that, is sort of low to start with and then steadily increases towards the middle. The middle is where ovulation happens. And then it drops and then it goes up a little bit again and then drops back down again. Whereas progesterone is pretty much, it's very low throughout the whole of the follicular phase, of the first part of the cycle. And then after ovulation, it climbs really high. And then in the second phase, which is the luteal phase, and then it dips again, takes a bit of a nosedive, which is what kind of triggers a period to happen. So the whole purpose of this is to drive the development and the release of an egg cell or an ovum from the ovary, and also to create a nice place for a fertilised egg cell to implant in the endometrium. If an ovum is fertilised, then it can implant in the endometrium where it's nourished by all that lovely blood. If the egg is not fertilised, then the endometrium can break down and then the whole cycle begins again. And we also see these changes in basal body temperature at the kind of top panel. So cooler in the first half of the menstrual cycle and warmer in the second half. So essentially, like, there's a lot going on behind the scenes. So all of this is sort of happening, and obviously we can't really see any of it. So you can imagine that if we've got all of these kind of physiological and chemical processes going on, changes to our temperature and everything, it's going to have a pretty big knock-on effect for women's health. So I'd like to introduce the concept of menstrual health, which is defined as a state of complete physical, mental and social well-being in relation to the menstrual cycle. Good menstrual health means that all people that menstruate are able to access accurate information about menstruation. They can access bathrooms and menstrual products to care for their bodies. They can access timely health services, and they experience or can expect to experience a positive and respectful environment free from stigma and psychological stress, and also not be excluded or restricted from participating in all of the activities that they might want to participate in at any stage of their cycle. So we know that physical and mental health are linked, like that's pretty clear, and so it won't be surprising, I hope, that menstrual and mental health are linked. And so in this section of the talk, I'm going to outline some of the ways that happens. So firstly, I've already defined mental health. I just want to briefly talk about what I mean by mental health. So the main kind of take home here is that the definition of mental health that I'm using is really broad. So it's not just the absence of a mental disorder, it's probably more in line with what you might call well-being. So it's the foundation for the well-being and the effective functioning of individuals, and the ability to think, learn and understand your emotions and the reactions of others. And it determines your behaviour, how you handle stress, how you relate to other people, the decisions that you make, and essentially just allows you to achieve your intellectual and emotional potential in society and just enjoy your life. I feel like I need to mention that my colour scheme is just not the colour scheme I wanted. My slides have come out differently and I'm not happy with it. So anyway, I'll take us through a few examples of how menstrual health might influence mental health. The font's wrong as well. So menstrual symptoms such as very heavy bleeding and period pain are sometimes associated with a lower quality of life and well-being, non-attendance at school and work, and higher rates of mental health disorders. So if you're in a lot of pain, you're unlikely to be experiencing your best mental health that day and achieving your kind of full potential. And this is compounded by the fact that stigma and a lack of knowledge about what normal means. Means that people often don't go to the doctor if they've got really bad menstrual symptoms. So menstrual disorders like endometriosis or polycystic ovary syndrome are often underreported and underdiagnosed. But we do know that they affect a really large proportion of the population. Next, maybe the most widely recognised link between menstrual and mental health is premenstrual syndrome, or PMS. So I found this meme on the internet, so I don't endorse it, but I think they highlight some of the really unhelpful and sexist attitudes around PMS. PMS is a set of symptoms, physical and emotional symptoms, that can occur about a week or two before a period. So after ovulation, in that kind of luteal phase where progesterone is high. And it can include bloating, breast tenderness, food cravings, difficulty sleeping, as well as changes to mood and feeling upset, irritable and anxious. Now, most people who menstruate will experience some kind of PMS symptoms at least at some point in their life course. For some people, they have really extreme symptoms that can affect their ability to work and socialise and have healthy relationships. And actually their mood might dip so low premenstrually that they might have suicidal thoughts. And those people might be diagnosed with something called premenstrual dysphoric disorder, or PMDD. Now, this is a relatively new mental health disorder, so getting a diagnosis is actually incredibly difficult because of generally just a kind of lack of awareness, even amongst doctors. So this is a quote from an interview with a woman suffering from PMDD, and she says, "You're fighting everything and everyone, including yourself. You don't have the energy to deal with everyone else. I was coming across as a hysterical young lady, and I think really big assumptions were made, and I just felt that my opinion and my voice counted for nothing." So I think you can imagine the kind of compounding effect of having to go through all of that and your PMDD symptoms and the sort of battle that you're going to have with your mental health in that situation. Next, access to safe, clean facilities, affordable menstrual products and sexual and reproductive health care are really important factors in shaping women's experiences around menstruation. So if you haven't got these things, then you're going to find it difficult to have good menstrual health, and that's going to have a knock-on effect on your mental health and your social well-being. So for example, if you can't afford menstrual products, then maybe you can't leave the house when you've got your period, or if you do, you might bleed through onto your clothes and risk ridicule and discrimination, and that's going to affect your mental health. Also, puberty is a particularly formative time in anyone's life. Around the time of the first period, we see these kind of huge hormonal changes that can affect physiology, anatomy, and mood and mental health. So you can imagine that early negative menstrual experiences could shape an individual's feelings about menstruation, and that could last into adulthood. So one thing I find really interesting is, so the average age of periods, of a first period, which we call menarche, is around 12 to 13. But if you start periods early, that's associated with a higher risk of depression in adulthood. And one of the hypotheses is that maybe some adolescents are starting their periods kind of before they're prepared. So potentially really good quality education around that time for menstruating adolescents, but also for their non-menstruating peers, might really help to kind of reduce confusion and stigma and improve mental well-being. And then the other end of the reproductive life course is marked by the cessation of menstruation at menopause. So we see huge, again, hormonal changes around that time that can result in a wide range of physiological, emotional and cognitive symptoms, including hot flushes, feeling anxious, irritable and depressed, and poor memory. And obviously all of these physical and mental symptoms can affect a woman's ability to have a good quality of life, and to maintain relationships, to socialise, to work, and all of that's tied up with good mental health. So hopefully that's explained how menstrual and mental health can be linked to each other. In the next part of the talk, I just want to talk about what we don't know, and also how research can help us learn more. So some of you might have read or heard about this book, Invisible Women by Caroline Criado Perez, which outlines many of the ways in which vital data on women is lacking. So the male experience is kind of seen as the default, and the female experience is seen as niche or even abnormal. And this includes in healthcare. So there's a huge gap in healthcare. So although women live for longer in the UK on average, they spend a greater proportion of their lives in ill health. And independent reports and inquiries have shown that women are often failed by the healthcare system and not listened to. Last year, the Department for Health and Social Care carried out a consultation on women's health, and they published their strategy earlier this year, and they identified research evidence and data and women's voices as two of the areas where we really need to do more. So those are two areas that we're hoping to speak to with our research. So in 2021, I led the setup of a new network of researchers interested in the links between menstrual and mental health. So we're called 4M. It's taken a while to come to the name. I'm still not happy with it, but anyway. We're called 4M, and the M stand for menarche, which is the first period, menstruation, menopause, and mental health. And we're made up of researchers from multiple institutions and also multiple disciplines, so things like epidemiology, biology, medicine, psychology, social science, law, we've got management studies, we've got some people from humanities, so lots of different perspectives. And here we are. We're all very attractive. We're interested in combining our skills and our multidisciplinary perspectives to conduct research to find out more about the links between menstrual and mental health, and potentially interventions to improve health. So it's really early days, But we have some ideas about the most important areas of research. And one thing we'd really like to do is to collect really good quality biological, psychological, social data on people's experiences throughout the menstrual cycle. And I'm really particularly interested in the idea of tracking as a kind of intervention. So the idea that just by tracking their experiences, people can feel more positive and kind of more in control of their menstrual and mental health. And maybe this will help explain what I mean. So this is a pretty accurate representation of my experience nearly every cycle. So unexplained stress and anxiety, followed by like the relief there. It's probably PMS and not my personality. So certainly with women with PMDD have said that noticing the link between their cycle and their PMDD symptoms was a really important part of their coping. It's also a really important part of them getting a diagnosis. So this interviewee said that tracking or keeping a diary was key to understanding what was going on, so understanding the ups and downs of every month and being able to work out that there is a pattern. So so like I said, we'd like to collect this kind of frequent data on experiences throughout the menstrual cycle. So this includes questionnaire data, frequently collected data from digital technologies, so things like smartwatches and sensors on smart rings, which can pick up things like heart rate and temperature quite accurately. We want to collect biological samples. And so this would allow us to look at like hormone levels and also genetics. Now it's quite difficult to collect biological samples because normally you need to get people to come into the clinic, and if we want to collect very frequent data, we can't really do that every day and expect them to kind of come into the clinic every day, or expect a research nurse to go out to them every day. So these cards are something we want to explore the use of. And basically people make a little prick in their finger using a tiny little lancet and then just dab their blood onto those cards, and then they can just stick them in the post and send them back to us. And this as well as a urine dipstick test for ovulation. So they don't need to post these to us, but they just do it in the urine, and then they'll be able to work out which day they get their kind of LH surge, which happens just close to ovulation, and they can tell us that, and we can work out if they're ovulating and when. And we also want to collect what we call qualitative data, so data on women's experiences through things like interviews and focus groups. And we want to explore the use of this photo voice approach, which is where we ask participants to take photos of their menstrual experiences, and then they come to workshops and talk about their experiences through the photos. But these are just kind of our ideas, and we're just like a bunch of researchers. So one of the really important things about our research is stakeholder engagement and what we call co-production. So this means speaking to people who are going to benefit from the research and finding out what they want us to look into, and then including those stakeholders and the research participants themselves in our research, so designing it with them and involving them every step of the way. So just really listening to the voices of women and people who menstruate. And we really hope that by collecting more data and conducting more research, we'll be able to make a tangible impact on women's health by improving menstrual and mental health and the links between them. So historically, we've not done a great job of coming up with effective and ethical ways to improve women's health. So back when people believed in their wandering womb, women were advised to settle their naughty uteruses by wafting acrid or fragrant fumes, either at the face or the genitals, depending on which way the uterus had gone, to try and sort of tempt it back into its natural place. And then one idea was to kind of blast the genitals with water And I'm not sure where we'll achieve through, but it does look quite messy. This guy, Isaac Baker Brown, he was really big into the idea of cutting the clitoris off. Yep, that was his thing. This woman, she's not having a clitoris. I thought she was having a clitoris cut off. She's not. She's having a genital massage to stop her from being mad. So, and this says this is an advert from a newspaper for Lydia E. Pinkham's vegetable compound, and it reads, social tragedy. In the midst of one of the most brilliant social functions of the season, a noted society woman started suddenly from her chair with a scream of agony and fell insensible to the floor. And a few hours later, a distinguished physician told her anxious husband that she was suffering from an acute case of nervous prostration brought on by female trouble. And he hinted at an operation, which I'm guessing is Isaac Baker Brown's thing. Fortunately, a friend advised her to try this vegetable compound, and the result was that she escaped the surgeon's knife and today is a well woman, which is just such a lovely story. What a great friend. But like the main thing is I really doubt that any of this was evidence-based. There's still a lot of nonsense going on today, so based on kind of very weak or non-existent evidence, we still don't have good treatments to help women who menstruate because the research just hasn't been done. So this is taken from the website of a company that claims to empower women and people who menstruate by flogging things to them, essentially. So this is some CBD oil that it claims will help PMS. Now, I'm really not commenting on whether or not the efficacy of CBD oil for helping PMS. Like, maybe it works, but there's literally been no research, so we should probably do some research on it. The main problem here for me is that it's 30 quid for this tiny little bottle, tiny little plastic bottle, and I think it just screams exploiting female consumers. And it's also called Balance Oil for Moody Babes, which I hate. And it says on the website, real ingredients, zero bullshit, which I think is just... I mean, we literally don't know if it works, so it's potentially 100% bullshit. I won't spend too much on this slide, but also you can get this from CBD oil in Holland & Barrett for significantly less money. And it doesn't patronise you by being called moody babes. So we definitely need treatment, we need better treatment. So currently, many PMDD sufferers find that the most effective treatment for them is a complete hysterectomy, so complete removal of the uterus and the ovaries. So basically major surgery and sterilisation. And I just think they deserve better, like it's not good enough. And for people who have less severe but still poor mental health in relation to menstruation, perhaps something like women-centred psychological therapy around self-acceptance and self-care or hormonal treatment might be more effective than interventions that are traditionally used to treat mental health issues like antidepressant medication. So it's about kind of having a bit more awareness of why these problems are arising and not having this kind of blunt instrument approach. So crucially, we need any new interventions. Look at the colour scheme, it's so bad. It was so nice before, I promise. So crucially, we need any interventions to be backed up by science and evidence, so we need more research. And more research will help raise awareness about the links between menstrual and mental health. And more awareness means we might get more funding, not just for research, but also in healthcare and for charities that help, for menstrual and mental health charities that help support people. And we might be able to normalise talking about menstrual and mental health and not consciously or unconsciously excluding or restricting or discriminating against people while they're menstruating, meaning hopefully less stigma and taboo. This is like a depiction of less stigma and taboo. Jumping around, swirling ribbons. And we might be able to create better policies and practices, for example, in a workplace and at school, to help support people when they're menstruating, and also to minimise the impact on their social well-being. So I really hope that you agree with me that menstrual and mental health are linked in lots of ways, and more interdisciplinary research needs to be done to help women to understand and cope with their mental health throughout their menstrual cycles. So yeah, thank you so much for listening. I just want to highlight some mental health charities that that offer support specifically tailored around menstrual experiences. And thank you